Good morning. Thank you very much for the invitation to speak today. I was given 15 minutes by the organizing committee to speak about fertility preservation in prepubescent boys. But the funny thing happened this morning while I was having my breakfast and reading my Instagram feed. This story popped up. Heart Evangelista, the fashion icon du jour, shared her experience about IVF. She had IVF. She has two more embryos and will be implanting these embryos when she is ready. So she chose to, preserve her fertility. What an interesting segue to our congress on emerging issues on fertility preservation. Coincidence? I think not. Providential? Perhaps. But I'm sure most of you would rather find out if they're still together rather than listening to my talk on fertility preservation on prepubescent boys. So let's go. I'll start with a story of a 5-year-old male who was diagnosed to have a testicular mass, and it was found to be a stage 2C seminoma. He underwent radical orchectomy on the right, and after which he had 4 cycles of grueling bleomycin, etoposide, and cisplatin. After a few years, he was found to be cancer-free. The family was very, very happy. However, 22 years down the road, now he's 27, handsome, has a decent job, enough to buy him a car, and he now has a girlfriend, and they were ready to take their relationship to the next level, and they decided to get married. After getting married, they had enough money to build their dream house. Everything seemed complete, but there was one thing lacking. They wanted to have children, and so they tried to have children. But after trying for 2 years, they were unsuccessful. The man went to a urologist and consulted. A semen analysis was done, and he found out that he was azoospermic. There was no sperms in his ejaculate. Which brings us to the point that cancer treatment can actually cause male infertility. Do not forget. And brings us to the term fertility preservation. Fertility preservation, seemingly such is like a pseudo buzzword now. If we look at on PubMed, on the articles displayed throughout the years, clearly there's an increasing number of articles mentioning fertility preservation. Aside from another buzzword is oncofertility. Oncofertility is the subfield that bridges oncology and reproductive research to explore and expand options for the reproductive future of cancer survivors. It was coined by Teresa Woodruff from Northwestern University, and she coined it in 2006. And if you look at it, all articles throughout the years have been increasing until 2021. It's similar to a buzzword. However, we don't want these words to be just buzzwords. We want it to be part of the vocabulary of the standard of care in due time. Shameless plug that the PSFP is part of the Oncofertility Consortium as well. But to continue, each year approximately 400 children are diagnosed with cancer. And if we look at the local data from Globocan, from ages 0 to 4 to 19, most of it are dominated by the leukemias and the CNS tumors, which is similar to the worldwide data as well. But the incidence of cancer is clearly increasing worldwide. However, there is a decrease in cancer deaths significantly. Why is this so? Mainly because of the recent advances in number 1, surgery, number 2, chemotherapy, number 3, radiation therapy. As a result, more and more children and adolescents are surviving the cancer. As a result, quality of life is now in focus rather than the cancer itself because of the whopping 8% survival rate of childhood cancers and the current treatment options they have. So which means more and more children are surviving. And this child that survives will gradually grow into a pubescent child and definitely to adult. Which brings us to another subfield called survivorship, which is the long-term effect of toxicity from chemotherapy, radiation, and even surgery for that matter. Which means boys and adolescents are at the risk for infertility when they get their treatment. Which brings us again to our topic of fertility preservation. For a normal male, adult male, sperm cryopreservation is the most ideal form. So example, for the male, the sperm retrieval goes through ejaculated sperm, through masturbation, and the sperm that's ejaculated is frozen or cryopreserved. That's simple. However, for adolescent boys who already produce sperm, sometimes masturbation may be an issue. They most refuse to collect for several reasons. One, they're shy to talk about it or do it with a parent or legal guardian around, and most are consider religious and ethical reasons considerations, especially in the Philippines. where a lot of boys are from Catholic schools, where we're indoctrinated to say masturbation is a sin, although it makes you feel like heaven, but they said you'll surely go to the gates of hell. Which brings us to sperm retrieval methods for those who refuse to masturbate to get the sperm. The options include testicular sperm extraction, where we puncture the testicle with a needle subcutaneously, and semi-nitreous tubules are extracted, but this is done under anesthesia. And of course, microtester or microdissection testicular sperm extraction, wherein we open up the testicle and look for pockets of sperm production in the seminiferous tubules. What about a prepubertal child? What are his options for fertility preservation? Well, the problem is prepubescent children do not produce sperms just yet. If you look at the growth of a child from an infant down to adolescent and an adult, they start off with spermatogonial stem cells when they are born. They produce primary spermatocyte as they age, secondary spermatocytes, spermatids, but only produce spermatozoa when they're after puberty or during puberty. And this moment is called spermaceae, when they release spermatozoa already. So for the late adolescents, as was mentioned, sperm retrieval is easy, and sperm cryopreservation. But the problem is with these children who are prepubescents, which is the topic for talk. We can't freeze their sperm because they don't have no sperm. So what we do is testicular tissue cryopreservation. We freeze the testicular tissue with the spermatogonial stem cells. But again, we would like to remind this is all purely experimental. But these experimental therapies that are in the pipeline may soon emerge that will make producing sperms very, very much possible. We'll show you why. So how do we get testicular tissue? One, of course, we can do a testicular biopsy. It's under local anesthesia or general anesthesia, wherein a sliver of tissue is taken, sometimes larger chunks, or sometimes the whole testicle for that matter. But remember, this must be done before treatment starts, before surgery is done, before chemotherapy is done, before radiotherapy is done, not during, not after, so that we can get the best fertility outcomes. To understand this, we want to discuss the spermatogonal stem cell, which is the precursor for producing sperms. And this is the main point why we do these fertility preservation options, because of the spermatogonial stem cells. So what are the ways we can do it? The first one is spermatogonial sperm cell transfer. So how is this done? So a testis biopsy is done and taken, and it's formed into cell suspension, after which the spermatogonial stem cells are cultured. And this culture is injected after treatment when the child is already an adult and is cancer-free. It's injected in the testicle, specifically in the retitestis, for equal spread. And once it's injected, after a few months, sperm is produced in the testicle. And once produced, the sperm, if in adequate number, can be used through pregnancy via just simple intercourse, or if in very small amounts, it can be retrieved and IVF or ICSI is done. Currently, this has been done on mice, hamsters, dogs, cats, goats, sheep, monkeys, and even pigs. And these have been successful. They have been documented in several studies, but none have been successful in humans just yet. But I'm sure that's pretty soon. It's going to come pretty soon. Another option, which is quite experimental and not very promising, is de novo testicular morphogenesis. And how do we do it? From the same testicular tissue that was taken, cell suspension is done, and these are cultured. And when we cultured, it is cultured to produce, the testicular elements, which include Leydig cells, and other cells that can produce the sperm. And once this de novo formation is formed, sperms are produced, and these sperms are recovered, and ICSI is done. It's that simple, but it hasn't been done yet. Not very, very promising. And protocols are quite varied, so they can't. Standardization is quite difficult. And perhaps the other most promising, aside from the stem cell transfer, is autologous grafting. How is it done? So again, it's from the same tissue that was taken. These are cryopreserved right before treatment. And after treatment, and when the patient is cancer-free and an adult, this tissue is actually implanted and grafted underneath the skin, and after which it actually produces sperm. And once the sperm is extracted and used for ICSI, we've been successful. This has been successful. Xenografting, on the other hand, is using a different species where testicular tissue is taken and injected into mice, and it's placed in the skin underneath the mice in several areas. and after which sperm is produced and recovered in an ICSI is done. Um, to this to this day, since 2017, the first one was extracted. The first graft was done and extracted, and it formed a huge tissue underneath the skin. And after a few months, they noted sperm in the area. So this sperm was taken and extracted and produced an embryo. And after a month, pregnancy was confirmed. And after which the first graft-derived baby was born in 2018. His name is Grady, or short for graft-derived baby. And he is doing well at the moment. And he's a normal child. He's being monitored. So which brings us to our program, which is in St. Luke's CARMI, Pubertal Testicular Tissue Cryopreservation. It's the only one of this kind in the country, and in the first one in the country to offer this service and program. We started out with a protocol for prepubertal testicular tissue cryopreservation, mainly based and adapted from the University of Pittsburgh and to the group of Dr. Carl Orwig, and the University of Miami to the group of Dr. Ranjit Ramasamy, who guided us. So now I won't go through it, but I'll just give you some highlights which are quite interesting. First is the consent form. Since the patient is a minor, consent form is given by the guardian. Again, we always state that it's an experimental procedure that may possibly restore fertility. Stress on the experimental. And consent will be reissued once the patient reaches 18 years old. However, if the patient dies before 18 years old, the consent is not of using the tissue is not. The tissue will be discarded rather than used for experimental purposes. So inclusion criteria includes prepubescent males who will undergo or have undergone surgery, chemotherapy, radiotherapy, or drug treatment with the risk of permanent and complete loss of testicular function. And also they may have a medical condition that requires removal of all parts or both of the testes, especially in testicular cancer. And these tissues that are harvested, some are sent for histopathology for diagnosis, and the rest is sent to CARMI for cryopreservation. Again, what can we take? One, we can take the whole testis, especially in patients who had an orchiectomy. Number two, we can take chunks or tissue, or 25% of the testicular tissue can be taken. And of course, small tissues measuring around 100 to 500 milligrams can be taken. Like a whole chunk can be taken. Here's an example, small piece, or just slivers of tissue. These are all our actual patients. Again, how do we transport the tissue? Testicular specimens will be rapidly submerged in a media, which is the blastocyst media, and placed in a container, and it will be covered redundantly with 2 Ziploc bags and sent to CARMI. Here's an example of how it's being processed on the cryotubes. They're all placed, processed, and frozen. Here's it frozen in a cryo. So that's it. That's how it's done. At present, from 2020 to 2022, we only have a measly 4 cases total, and these are the demographics of the patient, ages 3 to 9 years old. But the problem is, what are the barriers and why we have such little patients? One of them is probably financial, but it's not really very expensive. Sperm banking, the first part is infection screening, which is inexpensive. We screen for HIV, syphilis, hepatitis, and of course, COVID. Sperm banking costs will approximately cost $9,000 a year, inexpensive as well. And the best part is professional fees. Urologists, especially pediatric urologists, do not charge very high. They actually charge low, and the fees are almost negligible. So another barrier is probably awareness. When I ask several pediatric oncologists, they're not even aware of this just yet. It's probably our fault. That's why we have these webinars on a regular basis, conferences and conventions to increase awareness of fertility preservation for prepubertal children. And to summarize, currently there are no fertility preservation options available for prepubescent boys who are not yet producing sperm. There are no human live births from transplanted testicular tissue, but progress in animal models is definitely promising. And finally, experimental techniques are currently being developed to provide future alternatives for patients that preserve their testicular tissue cells. And if that time comes, we'll definitely be ready whenever that time comes, and because of our program of cryopreservation of testicular tissue on prepubertal boys. Thank you very much.